Today we will be discussing about hepatocellular carcinoma, the details which will help you to fill the data into the entry system. So introduction. As we know, hepatocellular carcinoma is the most common type of primary liver cancer in adults. It occurs in the setting of chronic liver inflammation. That is that what happens in the chronic viral hepatitis B or C, or even when people are exposed to hepatotoxins like alcohol or aflatoxin, that may ultimately lead to liver cirrhosis, and that is the precipitating factor that is supposed to uh, lead to hepatocellular carcinoma. Also, metabolic syndrome and non-alcoholic steatohepatitis, that is long-lasting fatty liver, where also the final pathology is cirrhosis, that will lead to hepatocellular carcinoma. This is the global picture. As you can see, India hepatocellular carcinoma is more than 11th in place compared to the Western population. The story of gastrointestinal cancers, the overall burden. Here, both the incidence and also in mortality, this constitute in the top 10 cancers all around the world, but unlikely in India. So baseline history, hepatocellular carcinoma develops through fibrotic degenerative process with the formation of nodules called cirrhosis. So far, HCC is the most common cause of death in people affected by cirrhosis. Patients affected by hepatocellular carcinoma will have signs and symptoms of chronic liver disease. That's jaundice, ascites, abnormalities in blood coagulation, hyporexia, weight loss, abdominal pain, nausea, and vomiting. So symptoms um, symptoms and clinical presentation. So the patients with advanced HCC may present with mild to moderate abdominal pain, weight loss, early satiety, or with a palpable mass in the abdomen. Sometimes they may not have any symptoms at all. In some cases, HCC patients could present worsening of the symptoms. So investigations, as for any patient, basic blood investigations would be done. That's complete blood count with hemoglobin, platelet count, WBC count, renal function test, liver function test, albumin, and here one additional test comes, that's coagulation profile, because as we know, liver is the manufacturing area for almost all proteins in the body, including the coagulation proteins. And tumor markers, serum alpha fetoprotein, which is very useful in both diagnosis, also response assessment and follow-up of these patients. Then microscopy, true cut biopsy or endoscopic ultrasound guided fine needle aspiration. This can be done in selected group of patients. The basic lesion that's found in the liver, that's nodule, that usually progresses from a regenerative micronodule of cirrhosis to regenerative macronodule with histological changes that lead from mild to severe dysplasia to carcinoma, extending into the entire nodule and beyond. This is the basic pathophysiology of cirrhotic nodule progressing into a malignant nodule. Molecular testing, as for now, there are no specific molecular testing in hepatocellular carcinoma. Pathology, this is important in the resected liver nodules. They may mention the tumor size, number of nodes resected, immunohistochemistry. It's not routinely done in hepatocellular carcinoma unlike in other malignancies, because it's a macroscopic and microscopic diagnosis, and LVI stage as per the TNM classification we have to look into. Radiology, the contrast enhanced MRI or CT scan to identify diagnostic pattern typical of HCC. That's there are, as we know, there are three phases: arterial phase, venous phase, and late phase. In hepatocellular carcinoma, there will be contrast enhancement, that's hypervascularization, and also washout in both the three phases. Lesions with atypical appearance that doesn't have this typical three-phase enhancement. In such cases, further evaluation with biopsy may be recommended, especially if technically feasible, then only, because these lesions have high chance for bleeding. Coming to the treatment, when hepatoscellular carcinoma is suspected, you have to look into the EASL criteria, whether it's fitting into diagnosis. Otherwise, we will have to plan a biopsy of the lesion. Then assess the liver function test and also performance status of the patient. Then we have to choose the treatment according to the stage group in which the disease belongs to. If the patient has preserved liver function and there is only one nodule less than 2 centimeter, then we have the option of ablation, resection are there. If there is intermediate liver function, multiple nodules, TACE can be attempted. I'll come to that TACE part little soon. Then transplant, if the liver parameters are deranged and one nodule with less than 5 centimeter size or 3 nodules more than 3 centimeter size, that's the criteria for transplant. Systemic therapy is considered if the preserved liver function, or in rare cases even intermediate liver function with advanced or metastatic stages. Systemic therapy can be planned, but in terminal stages only best supportive care would be the ideal treatment of choice. Then, as per the number and dimension of the nodules, this is the criteria that will help us to determine whether we are considering liver transplant, liver resection, or any portal vein embolization. Here also, when the patient progresses or becomes metastatic or childhood C, at that time we have to consider systemic therapy. In other settings, we can attempt curative modality of treatment. In advanced or metastatic disease, we have to categorize the patient into whether it's child book B, A, or C. When child book C or unfit child book B, best supportive care would be the best treatment option. Otherwise, we have first line sorafenib or lenvatinib. When they progress, we can try regorafenib or cabozantinib or even immunotherapy. Then these terminally ill patients, palliative care should be added along with the treatment. That helps in improving the symptoms, controlling the pain for quality of life, and also to prolong life. It's not a curative approach. The final goal would be tumor control or tumor shrinkage that will ultimately lead to control of the pain. Response assessment, we will serially be monitoring for clinical examination for how's the liver is subsiding, how's the ascites or any organomegaly that's improving with treatment, and serum alpha fetoprotein, how it's coming down after treatment. Also serial imaging, whether it could be ultrasound, CT, MRI or PET CT according to the patient's preference and health condition. Follow-up also, we have to serially do the clinical examination, do the monitoring of serum alpha fetoprotein once to 4 to 6 monthly once. Any imaging or assignment required should be done. Relapse can be diagnosed during follow-up while checking serum AFP monitoring and also by imaging. And curative approach treatments are not available for recurrence and metastatic disease. Palliative treatment will be chosen in such situations. Treatment toxicity and rehabilitation. Liver transplant patients will be on long-term immunosuppression, and they needs to be closely monitored for infections and other toxicities. Once metastatic, this group of patients will have worst problems.